Dan, this is David. You're usually just wearing a regular surgical mask, and you look like you're wearing something like more protective today. So I guess maybe to start out with is how's COVID affected you over the year, and how have you changed?
So I'm wearing an N95 instead of my regular cloth mask, but it really doesn't reflect much except inconsistency, David. But as everybody knows, just about every county in West Virginia and almost every county in the United States is red, going by the Harvard map, which uses I believe it uses greater than 25, a 7-day rolling average per 100,000 population, greater than 25 new cases. So yeah, we're all influenced by the greater incidence of coronavirus cases, and so we are being more careful. And I'll be putting on my face shield in a couple minutes. How about other places? And the other places that we have with us today, besides New River, are Preston, Armstrong County in Pennsylvania, and Hygeia in Whitesville with Beth Hudspeth.
So at Preston, we're still running pulmonary rehab. We're still doing one patient at a time. We have suspended our phase 4 maintenance patients for now, but we're still, running one patient at a time, and we feel like it's been safe. We've had most of our patients continue. We've actually been able to even start some new ones and graduate some old ones during this time. We're red in Preston County. We're just doing what we can to keep an eye on things and make sure that we are protecting our patients as much as possible. We did roll out the COVID vaccine last week, and so I was one of the first ones to get the vaccine. So hopefully, there's a light at the end of the tunnel, I hope.
Hi, this is Sam, and I'm not in your area. I'm down here in almost a foreign country called Texas, but I notice, at least amongst my fellow Texans, that it doesn't seem that as much as we tell people about, wearing your mask, keeping your distancing, and washing your hands, that, one time or 2 times or even 3 times of reinforcing this message is getting through to some people. Does anybody have any other ideas besides bopping them over the head and tell them to listen to us? I guess the silence indicates a no.
No, Sam, it's so frustrating. Preston County 2 to 3 weeks ago, we were green. We had minimal cases, minimal community spread, and it's just, ever since Thanksgiving, it's gone like wildfire. And you tell people and they're like, oh, I'm okay, I was only at my brother's house or my sister's house or my kid's house. And I had a patient tell me the other day that she's staying with her daughter and her 3 grandkids, and she said, but they don't go anywhere. They've been on virtual school since March, and they're not doing anything. And then the next sentence she said, well, my granddaughter, I'm so proud of her, she's got a job at a nursing home that she's working at. And I'm like, it's so frustrating that they don't see the connection. It's wonderful, but at the same time, her granddaughter is a vector that's bringing stuff home every shift she works. And I just don't know what to tell people. You try and you try and you try, and it doesn't seem to get through. It's so frustrating.
Well, Allison, what would you tell her or her granddaughter they should be doing instead?
Well, I told her that her granddaughter can be bringing it back from the nursing home, and that they've got to be careful. Her granddaughter needs to make sure that she's wearing protection, that she's washing her hands, you know, and you know, they really have to be careful. This conversation actually was in context of the flu. I was trying to get her to get the flu vaccine to protect herself on top of everything else she's doing to protect for COVID. But, you know, as far as COVID goes, as long as her granddaughter is wearing the protection that she needs to be wearing at work, you know, I wouldn't really tell her much different. But I was trying to explain to her that if she got the flu and got COVID, it would be detrimental for this COPD patient.
Well, there's something that, I'm sorry, this is Sam again, but I wanted to get this to you before I forget it again. And I'll tell you a story, and this gave me an idea about instructing people to bring handkerchiefs with them. And my wife was someplace and you know, buying something, and everybody had on masks. And ahead of her was this rocket scientist who had to sneeze, and he pulled down his mask to sneeze. Then he put his mask back up. And then, you know, a few seconds later, he had to sneeze again. He pulled down the mask. Well, my wife, who's very nice, you know, certainly mentioned some things to them. But I think the point was he didn't want to get anything in his mask. And if we all carry handkerchiefs, so that if we have these, shall we say, wet sneezes, if we do have that, we want to keep our mask relatively clean. At least we can guide people to say, hey, pull out a handkerchief, keep your mouth covered when you sneeze. Just a thought.
Wet mask is a never-ending battle I have with my 5-year-old, so between chewing on it and everything else. So I understand, you know, and at least this person understood that a wet mask isn't going to protect you, but yeah, sneezing into open public it's not a great idea.
Well, I count him with all the people that like to hang their noses over the mask.
Well, wearing a mask is like keeping a handkerchief over your face all the time. Sort of defeats the purpose to take it off.
Exactly. Well, what should we tell people who are at risk and are on the list to get, are in the category to receive their vaccines early? Should they contact their physicians, or do they rely on their physicians to contact them? I've heard it both ways. What do you all think?
The former.
Agree. Squeaky wheel gets the grease.
And your patient's granddaughter should be on the list to get it this week or next, Allison, as a nursing home worker.
Yeah, she's in Baltimore, so hopefully Baltimore is the same tier as us, but I hope so.
Yeah.
You know, Dan, this is Kim. I wanted to react. Colonel Peel actually asked me to join the immunization rollout team in West Virginia last week and work with the faith community and nonprofits. And I think that if your doctor is at an FQHC or a health department, then you might get the vaccine quicker. But if you're in a practice with one of the larger hospital systems, I don't know that you're going to get the vaccine as early as the pharmacies. So I think I would say to elderly people, find out. I think we have a responsibility of finding out when there's going to be clinics for the 80 and older, 70 and older, 65 and older with chronic diseases, which of course all of our folks we work with would qualify for, and send it to them. And then Dr. Walker is calling his patients. Actually, he's having folks that he works at Lincoln Primary Care. He's on my board. That's why I gave him as an example. So he has someone calling all of his patients to say, when you're offered the vaccine, you need to take it as soon as you're offered, as long as you're well. Are you planning on doing that? Do you have any questions? And if they say, yes, they're taking it, then they say, we'll put you on the list when it comes in, that we're going to call you and sign you up, because you have to be signed up. And then you can't just show up. And then if they say no, then Dr. Walker's personally calling them and asking them what their concern is, and if he can, you know, talk them through that, just like you guys are talking through flu. But I think it's going to be a heavy lift.
Yeah, and I think what they're doing is wonderful. The wonderful model. I don't know if we can call it best practice, because he's such an outlier that but it certainly is a best practice, and it's a great example of what a model practice can do. Actually getting FQHCs to do that with thousands of patients. I mean, in New River, Cabin Creek, Beth down at Hygeia in Whitesville, and love to hear from you about how things are going, Beth and Aaron. The situation we're in is that people who might have done that have been laid off. We are understaffed. I just heard last week that CAMC closed their COPD and CHF clinics that they were running for patients being readmitted, and transferred that role into a pulmonologist's office, where basically they had a program for making sure that any COPD patient who was discharged had a visit within a week to 10 days. And so it's a great thing that they're doing. And I'd love to say that all the FQHCs and primary care practices should be doing that. But I also know, like you said, that it's a very heavy lift, particularly when this pandemic has led to layoffs and shortages of staff. I mean, it's hard to just have nurses showing up to check patients in for the doctors who are there. So as usual, we have the stress between what we should be doing and what's actually getting done.
Kim, this is Allison. I have a question. I've been seeing reports that pharmacies are getting the COVID vaccine. How are they going to be distributing it? I mean, I know at the hospital they've said, you know, this is tier 1, but how does the pharmacy, what's their plans for distribution, and how do they verify the information?
Well, Allison, have you seen the full plan? If not, I'd be happy to send the full plan. Every state should have a plan, and West Virginia has a pretty robust plan, and it lays out how that occurs. So they're not doing standing doctor's orders, because that would just impede the process. But, you know, the pharmacist would have how old the person is and know what medications they're on if they're a chronic condition, but it would still go down the tiers. It's still being done, you know, in the order of, you know, critical healthcare folks, essential workers, elderly folks, people with chronic disease. And then, you know, it's phase 1A, 1B, 1C, and then teachers, postal workers, things like that. So the pharmacists should still be doing that. The problem is we're getting limited vaccine across the nation. So you just have to go in order of need is what they're trying to do. And of course, congregate living was in there. Back to the FQs for a second. Even if we had our respiratory therapist call all of our patients and get them cleared that they want to take it. So when you get vaccine, because each vial has at least 5 doses, but they're finding some vials have 6 and 7 doses. So you have to line up about 8 or 9 people, because some people might come in with a fever or not be able to take it that day for some reason, and you don't want to waste a dose for any reason at all. So Allison, I'll send the plan. I don't know if I've answered your question, but I can ask more specifically. But pharmacies for rural folks are sometimes easier to get to than a doctor that might be in a different city, as you know, where you live. But I think we have to say, when offered, do it. Whatever's easiest and quickest for you and safest for you, do it. If it is your doc, great. If it's not, do it at your local pharmacy. and have somebody go with you, because I go with my father, walk in and see how many people are there, and then walk him straight back to the room so he's not in contact with anybody. And if FQHCs, we did the numbers, 80,000 people are 65 and older. That's a lot of people that we could vaccinate if we could get the vaccine to the FQs. Not saying others shouldn't get it too, like rural hospitals, Allison. I'm not saying that. It's just 1 in 4 West Virginians medical homes at an FQ. So that's got to be one of the places. Health departments would be another free avenue. And then ability to pay is not supposed to be an issue either. They will bill if you have insurance, but if you don't have it, it's free.
One of the talking points that I've been telling my patients, because I've had some pushback, you know, I don't want to be a guinea pig. I don't want to be the first one to get this shot. You know, this hasn't been tested. One of the things that I've been telling patients is that, you know, luckily for them, in the last 1 to 2 weeks, you know, we've had thousands of healthcare workers that have gotten this vaccine. And so in addition to the initial, you know, 30,000 that were in the first trial, there's now, you know, many more that have been vaccinated. And so, you know, hopefully that's something that gives the patients a little bit more hope and a little bit more comfort when it's their turn to get the vaccine. So I wanted to pass that on to everybody as well.
Aaron or Beth, you're at a couple different primary care sites. Well, Beth, I know you're in a hospital, but and Aaron, I see you're unmuted. What's happening where you are?
So we have not had the vaccine roll out yet. We are actually getting the Moderna brand. It's more feasible for our hospital, being we're only about a 160-bed hospital outside of Pittsburgh. So storage-wise for us, being able to store it in a freezer as opposed to the dry ice of Pfizer. So they're working on a rollout plan for us. We should have one, I believe, next week. We should be starting to get the vaccine here. Several hospitals in Pittsburgh have already rolled them out, the major hospitals, AHN and UPMC there. As far as the vaccine, as far as our pulmonary rehab, since we just opened literally in the middle of a pandemic, we have 2 patients, which we're super thrilled to even have at this point. And you know, everything's going well there. We just went through renovations of our cardiac and pulmonary rehab space, so everything is new. We have our website up and running, so we're kind of waiting for COVID to die down a little bit before we put on a full-on press to get any more marketing out there. We visited some hospital or from our doctor physician sites that aren't tied into or part of the hospital on site here. So we did do that, but you know, COVID wise in our hospital, we kind of got through spring pretty easily. However, now we're getting hit pretty hard. I think we have about 25 patients in-house now, various degrees of sickness, and it's kind of rolling through my staff at this point. So I spend about half of my day figuring out staffing. We have in our facility a skilled nursing unit that requires testing, COVID testing, based on the percentage of our county. So at this point, we are testing staff that is working on our skilled nursing unit twice per week. And a lot of them, you know, we're seeing it through all of the different areas: PT, OT, respiratory, speech, nursing. We're coming back with a lot of asymptomatic positives, and you know, quarantining those and trying to figure out staffing. So it's hitting us pretty hard in a small little hospital. I mean, my respiratory staff is a staff of 10 full-time staff members. So we're getting a little worn out and covering a lot of overtime just to make sure that we have enough staff here for the patients. So yeah, we were pretty good in the spring, but right now we're feeling it.
Aaron, as you observe what's happening in the hospital, and I don't know how much you get around, but how's it going in terms of staff compliance with mask use and staff compliance with mask covering nose versus nose sticking out?
In the beginning, awful, because, you know, the masks were underneath the nose and nobody really wanted to wear them. However, now we're, at this point, some of our units, we're requiring N95s. So my staff wears N95s on 4 units, whether they just walk in and they're walking through or not. I mean, the ER is, we use N95s literally every single time we walk in there. So the compliance is getting great. That is probably the only thing that is saving me from having about half of my staff off now. We had a potential exposure on Friday afternoon. I personally had to call 6 staff members to make sure that we were properly fitted and wore all of our PPE. And that truly is the only thing that's saving us from having half of my department quarantined right now.
Thank you.
Mm-hmm.
Hey, Beth, are you in a place where you can unmute and tell us what's happening down there on the Boone County, Raleigh County line? Maybe not. But if you get to where you can, it'd be great to hear from you. Beth Hudspeth didn't get to introduce herself, but she's a nurse, either PA or nurse practitioner who works in the Hygeia facility right near Whitesville, which is in Raleigh County, but it's just right near the Boone County line. And she's really interested in trying to figure out how, and she works in a FQHC lookalike. I'm pretty sure it's a lookalike, maybe FQHC. And she's been consistently coming to these echoes, and she and I talked a few weeks ago about what's going on there. They don't have pulmonary rehab, but she would really like to have pulmonary rehab there. I guess unless there are other things, or until there are other things, 2 things I wanted to bring up today are the status of the Grace Ann Dorney Pulmonary Rehabilitation Centers as a group. And it's kind of been expanded by some other APHP sites that have become part of the group. And then our partial success, limited success in establishing home-based pulmonary rehab. And I'd love to hear your perspective on this, Aaron, and progress from you, Allison. And these 2 things kind of go together. And then there's just the whole issue of, you know, Allison mentioned that they're just really glad to have even 1 or 2 patients. And Aaron, you didn't tell us if pulmonary rehab was still going. Are you guys still doing pulmonary rehab, Aaron?
We are still currently doing pulmonary rehab. We are fortunate enough to have a really large space to be able to do that, and we do them on opposite days of our cardiac rehab. So when pulmonary rehab is in there, since we only have those 2 patients, we only have those 2, and when we split them up, you know, in the morning and the afternoon. So we're only doing 1 at a time now, but we could probably fit 6 till maybe 8 or 9 if we push it, being 6 feet apart and being able to be on the facility. I did put in our website there, and it has a little video of our space and our updated space and different COPD and pulmonary rehab videos that we had our medical director do. If you all would like to take a look, that'll give you a little bit more of an idea of what we're doing here. And if you have any suggestions, you know, by all means, I'm open to any and all of them.
Yeah, that'd be great. Would you put a link so we can take a look?
Yep, I threw it in the chat box, and Mitra said she was going to put it in the recap also.
Okay, we see, yeah, we see it in the chat. So that's where there are videos about what it looks like and what you're doing?
Yeah, we have 2 different videos from our medical director here. One is on pulmonary rehab, one is on COPD, and then a 3rd video was just our marketing team took. It's a little lengthy, I think, but it gets the point across of our facility and what we have in our updated area that we can provide. So there are 3 different short videos, plus, all the verbiage, but we figured the videos would be, more people are going to watch the videos than actually read the whole page, so.
Right. And Kim, I don't know if you have your computer within your reach or not, but if you could put in the chat, if you do have it in your reach, if you could put it in the chat, or maybe Mitra will send it out, the link to the state plan that you referred to, the vaccination plan, that would be great. And if for some reason people don't get that, we can go to the WV West Virginia DHHR COVID website, and if you navigate around, the plan is also there. So in terms of pulmonary rehab, back in April, Grace Ann introduced us to Cheryl Flynn, who is developing a home-based app for pulmonary rehab, a web-based app for home pulmonary rehab. And ever since then, for the past 8 months, we've been working on trying to learn how to use that and get it implemented. And right now we have 4, Cabin Creek, New River, and Southern West Virginia health systems. We have 3 FQHCs that operate 4 of the Grace Ann Dorney pulmonary rehab sites, who those FQHCs have signed agreements with Blue Marble so that we're able to get the app. And now the respiratory therapists at those sites have the app and are in the process of getting it out to patients. And it's been pretty slow. It's discouraging how slow it's been. I partly think we had to learn to use the app. We had to get our patients to download it. We had to recruit patients to use it. Having people do home pulmonary rehab is a lot different than what we're used to in terms of in-person pulmonary rehab. Preston, I hope, is on the verge of getting that into the hands of their team. And you kind of got to have your hands on it and see what it is before you're going to really get it to patients. But we do have a number of patients at New River and at Cabin Creek. The exact numbers are at New River, we have 9 people signed up on Blue Marble app, but 2 of them are Carrie and me because we're test patients. We got 7 people, and of them, 3 are using it very actively. And at Cabin Creek, we've got about 4 people signed up, and 2 of them, 2 patients there, are using it actively. Southern West Virginia Health System, to my knowledge, hasn't signed any patients up yet, but both the respiratory therapists there have it figuratively in their hands. In their hands means downloaded on their computer. So ironically, the situation we have with COVID really gives us much more reason to offer this to patients and providers. So instead of saying, gee, it's a little bit like school. We're doing vaping education in school, and the teachers say to us, well, when we get back in class again, then we'll be able to do this. And we've been saying, no, do it now, do it virtually. We could do this with the home students. And it's the same thing with pulmonary rehab. Well, when this COVID pandemic quiets down, maybe we'll start getting our pulmonary rehab patients back again. No, we can do it right now with the home-based app. But we have to learn to do something different, and we have to help our patients learn to do something different. So that work is going on. In terms of our network, there at its peak, there were 9 at its peak in terms of the Central Appalachia Grace Ann Dorney Pulmonary Rehab Centers. There were 9 organizations running 10 sites. Right now we have, and then we lost 2. We lost 1 in North Carolina and 1 in Kentucky. So that put us down to 7 organizations running, I think 9 sites. Sorry if my numbers are wrong, but I think that this ECHO session, and particularly the first Monday of every month, is really an opportunity to bring that network together. And anybody who has any ideas about encouraging our co-respiratory therapists to participate, I would really appreciate them. Of our 7 organizations right now, there are only 2 on this call. Correct me if I'm wrong. Those are New River and Preston. Everybody else we're missing. So I think for me, a big kind of New Year's resolution is to reach out to those sites and get them to use this opportunity to come together and talk. And Mitra has been good enough to allow us to kind of use this as a time to get together. So for me, those are the 2 big things. And then along the way, we've added other groups like Beth Hudspeth at Hygeia, Aaron Erb, who's at Armstrong County Hospital in Pennsylvania. We have Pocahontas County that joined us. Tug River is interested. So we've actually expanded the group. And with home-based pulmonary rehab, it's actually possible for sites that don't have the space to do pulmonary rehab to start doing it, because what it really takes is a respiratory therapist or even an RN with a computer who knows how to use the app. We still have to bring our patients in for their intake and their graduation at the beginning and the end. But that takes a hallway to do a 6-minute walk test and the ability to do a pulmonary function test. So kind of that's the work that I see ahead of us in 2021. And there's no reason why this pandemic should stop us. If anything, it should speed us up.
Thank you for sharing that, Dr. Doyle. I totally agree with everything you said, especially with the resolutions for 2021 and how, you don't have to stop what you're doing, but that's awesome. Thank you. And I think you have a didactic coming up in the new year about the home-based pulmonary rehab. Is that correct?
You know the schedule, so I'm sure you're right.
Yep.
But that's more likely going to be a progress report than a theoretical discussion. We can demonstrate the app. Allison, one thing I'll say is that right now, kind of over the next couple of weeks, I think I'm going to probably sign up you and Kara on our Cabin Creek account so that you can get your hands on the patient version of the app. And as far as moving things forward at Preston, you know better than I where things are with that. Well, go ahead.
I don't know. The last I had spoken to Melissa, she was in the process of signing the contract, so I'm not sure if she's actually finalized that with Blue Marble or not, but I know she was working on it. So, and then there was another email that had come out through this group about reimbursement and documentation, and we sent that on to our financial person who was asking us about that. So that was like perfect timing. So
good. Yeah, Grace Ann was kind enough to send us, I think it was back in November, the something from Bloomberg Law that was sharing the CMS policy of paying for cardiac rehab and pulmonary rehab on a telehealth basis as long as this emergency continued. And I believe they said they would pay for it through the whole year, any year of emergency. So even if the so-called emergency ends in July, still we would get paid through 2021. And that gives Grace Ann and her other supporters and allies in Washington time to try to establish the reimbursability of pulmonary and cardiac rehab long term, even when hopefully this emergency is over.
Dan, I have a couple comments to make, and they're not as focused as yours. But I do want you to know that a working group of the ATS pulmonary rehab section that I'm a member of, it has just authorized, and we have funded a survey which will give us an opportunity to know actually how many pulmonary rehab clinics in the United States, both urban and rural, are still in operation, how many are suspended. And this is an update of Ira Moscovice's data. If you remember, it was published in Chest about almost 3 years ago. So there would be an update, and it would be open access. So everyone, every organization can have this list and be aware of where clinics are and whether or not they're being staffed, whether it be in person or virtually. Another update is that I found this fascinating. The same section that I belong to at ATS had a detailed webinar on Peter Lindenauer's work. He combed the databases of CMS and was able to show a mortality benefit for taking pulmonary rehab. So those who took pulmonary rehab lived longer than those who did not. And the interesting thing to me was that even 3 sessions of pulmonary rehab showed a mortality benefit. So if you have people who are resistant to taking pulmonary rehab, prior to this study, we really didn't have a firm basis to say you're going to live longer. We said you're going to feel better, you're going to have better function. This is very substantial. And the word has to get out that pulmonary rehab prolongs and enhances life. Then finally, a policy issue. Both last year and this year, the House bill has had a provision that would provide grants for chronic disease that are not represented in the CDC database, that are not funded, and COPD has never been funded. So the House bill last year and this year included language that would mean that the Senate bill would also conform to it. Well, it looks unlikely that that is going to pass because they are too wrapped up in the rest of the fiscal package. But Sam, you'll be happy to know that a budget neutrality for supplemental oxygen is probably going to pass. In fact, they clearly think it will. So those are the only updates that I have for you.
Well, that's good news. I hope they do it right. I still can't get people to order oxygen based on targeted saturations. Even ACCP has a document, a guidance document that I believe they're going to start distributing after the first of the year. And even in it, the language tends to be a bit discouraging of physicians, and this is aimed at physicians, but it tends to discourage physicians from prescribing portable oxygen devices. And it's unfortunate. But I do believe that this is the bridge to the future that cuts across the traditional supplemental oxygen delivery systems vis-a-vis cylinder oxygen, et cetera, but will also be applicable and usable in prescribing portable oxygen concentrators that are pulse dose based, which are not calibrated in liters per minute. I know it kind of glazes people's eyes over, but it's a necessary evil to talk about it sometimes.
It's one of our best medications for preventing pulmonary hypertension and keeping people out of heart failure and keeping them out of the hospital. It's really, really important. And it is true that the complexities of all the different equipment and what works and what doesn't, and the reimbursement do make it hard for us. But and then, you know, we know the difference between the NICE recommendations for use of oxygen and the United States recommendations. So it is complicated in that sense. But in many cases for us, it's just trying to get our patients to clearly have a need for portable oxygen to use it. You know, it's like, oh, it's out in the truck. Where's your oxygen? It's in the truck. You should have it on. Let us explain it to you.
Well, Dan, that's one of my concerns is the ergonomics of the, especially traditional portable systems like e-cylinders. You know, I started working in a hospital. I'm kind of a creature of hospitals. I actually started when I was 13 years old as an apprentice engineer, and I won't tell you what I had to do for that. But the bottom line is the e-cylinder carts that were used back in the late 50s are actually the same e-cylinder carts that we're trying to have patients use on sidewalks which have settled, which have cracks in them, or on just, especially in rural areas where there is no paving. And those carts were never designed to be used outside the corridors of a hospital. So a lot of patients leave the gear at home because it's too big of a hassle, and they'd rather be short of breath, struggle, or worse, curtail their physical activity.
Yeah, and that is so relevant to pulmonary rehab, because for me, the heart of the matter is people redefining themselves as invalids when that is not necessary. And two huge factors in allowing people to live and function at their full potential as family members, as grandparents, as workers, as community volunteers, are adequate oxygen supplementation and pulmonary rehab, teaching them how to be physically active. And so, and instead we see people believing that they're invalids and can't do anything. So I'm with you on that. And you know, for 40 years here, it's been clear that we needed a different kind of oxygen system for portable use, and we've just never had it. It's just not on the menu.
Absolutely. I'm thinking sometimes, you know, if hindsight being 2020, you know, we looked upon supplemental oxygen as we took the therapy part of oxygen therapy too seriously. Because let's face it, in many instances, we're not using it as a therapy. We're actually using supplemental oxygen as a prosthetic for the lungs. And I think if we can get that notion across to payers, we may be able to rejigger the payment system so that it's not as onerous in getting people access to the systems, the supplemental systems that fit their physical surroundings and their physical capabilities and limitations.
Yeah. So I don't want to run anybody off, but in my head I'm gonna, Mitra, start moving us toward closure. Everybody's busy, and nobody will mind being done early. Although it's not really early, but then I'm gonna say two things. Two other things. One, in terms of these echo sessions in 2021, I'll just tell you that my goal is always a case, and so that is the echo model, and so I keep encouraging our RTs and everybody out there and to submit cases, and you've made it very easy for us by always providing us the link, and you've been very flexible about not demanding that every single field be filled. So it's not that hard to submit a case, and so I'm going to keep working to try to translate our hundreds of cases that we deal with all the time into a few cases that actually get on our agenda. That's one thing. The other thing is I actually want to mention who's not with us today. Who's not with us today, who I wish were with us, are Willie Cart of Boone Memorial Hospital, Krista Clark and Krista Critchfield of Cabin Creek Health Center, Johnny Mullins of Southern West Virginia Health Systems in Man, Randy Bell of Southern West Virginia Health Systems in Hamlin, Tim Ritz at Jackson General, Lori Mullins at Roan, and wonderful respiratory therapist down in Big Sandy, who Grace Sandy we keep talking to all the time because they're doing great work on vaping education in the schools, Whitney Boland. And she came on when Ansel was and his team there started pulmonary rehab, and then for a variety of reasons, financial and geographic, they stopped. But I'm hoping they will start. And then at Hygeia, we have Beth Hudspeth. At Armstrong, we have Aaron Erb. So they're with us, but we're missing 1, 2, 3, 4, 5, 6, 7 really important people, and that's another goal for me. And I really think if we could get them together even once a month, and we've been shooting for the first Monday of each month. This is the third. So those are the things, and then continuing to roll out the home-based pulmonary rehab and the app that goes with it. Those are my Grace Ann Dorney, APHP, New Year's resolutions, and ECHO is a really important part of it.
Thank you, Dr. Doyle, and I, pun intended, echo everything you said for sure. And with the cases, if anyone ever has any hesitation with the case submissions but are thinking to submit something, don't ever hesitate to reach out. I'll go through it with you. And like Dr. Doyle said, not every field has to be filled out or anything, even if it's just a couple of things that you have on hand and can just bring to the sessions. It'll definitely help spark discussion and conversations and really helps to drive the session. So thank you, Dr. Doyle, for bringing up those really important points. And I know everyone is super busy, and especially with the new year starting, but if we could have the group, you know, like you said, at least once a month, that would be excellent. So well, thank you all so much.
What's our next, what and who is our next didactic?
Sure. Yep, Dr. Sela. So this was the last session of 2020, which I can't believe I'm already saying that, but the next session is going to be on January 4th, 2021, and Dr. Sela is going to discuss COPD exacerbation. So just keep an eye out for that. If, again, like I said, if there are any questions that come up during the holiday season, just feel free to reach out to me and I'll be right there to help you all in any way that I can. So thank you all so much. Dr. Doyle.
You got a case, or do you want us to come up with one?
We don't have a case submission right now. Dr. Sela, was there something like a mock case that you wanted to incorporate, or we can be creative and flexible with this as well?
And we can help if you want.
I didn't have any specific cases. I can certainly come up with a case based on a patient. Did you want it to go through the formal case submission, or did you want it just as part of my didactic? I usually do a case as part of my didactic, but.
Well, tell you what, send me your case in a Word, just send me your case in a Word file and I'll put it in. I think we need to get people to learn to use the case submission. It builds up a library of cases at the ECHO site for us.
Okay, I can do that.
If you want help doing it, we'll be happy to get it. We'll be happy to do that extra stuff of getting it into the form.
Okay, all right. I mean, I can even do it too. I've submitted cases before, so I can do that too.
Great.
That sounds great. Well, thank you all so much. I look forward to seeing you all in the new year. I hope you all have a really safe, happy, restful holiday season and a happy new year. So thank you all so much as always, and we'll see you guys next time.
Thank you, everybody.
Amen.